अस्सलाम वालेकुम सर। सर क्या हाल है, ठीक है?
जी ठीक ठाक बेटे, अल्हम्दुलिल्लाह।
अच्छा, डॉक्टर आलिया, आपको मेरी आवाज आ रही है?
हाँ, मुझे आ रही है फरोख आवाज। अस्सलाम वालेकुम सर।
वालेकुम अस्सलाम बेटे।
सर फिर आज का लेक्चर जो है डॉक्टर आलिया होस्ट करेंगी आपके साथ, और वो इंट्रोडक्शन वगैरह इनको बता दिया। तो 8 अभी बजने में मेरे ख्याल से 4 मिनट है, फिर जैसे ही 8 बजेंगे तो फिर हम स्टार्ट कर देंगे। ठीक है सर?
जी ठीक है, बिल्कुल ठीक। आज मुझे इंटरनेशनल कॉलेज ऑफ डेंटिस्ट से भी आया है, तो मैं उनको भी पार्टिसिपेट कर रहा हूँ। मैंने कहा है कि आप पार्टिसिपेंट जो है ना डायरेक्टली जो अपने चैनल से करने की बजाय आप इसी चैनल को करें कि एट ए टाइम मुझे यहाँ पे पार्टिसिपेंट क्योंकि कन्वर्सेशन आसान हो जाती है। तो इंटरनेशनली जितने हैं वो कन्वर्सेशन यहीं पे कर लें तो दैट इज मोर बेटर।
यस सर।
ठीक है सर। सर, आप एज अ प्रिंसिपल हैं, आपको कुछ पता है कि एनएलई जो है उसके रिफॉर्म्स क्या होंगे न्यूली ग्रेजुएट्स के लिए?
अभी बड़े बादल हैं बेटे, थोड़ा सा धूप निकलने दो, फिर पता चलेगा कि ये सारा क्या है।
सर
अभी तो
मसला खैरियत रखे।
अभी बेटे सारे बादल हैं। अभी you cannot say anything what is going on there because certainly the people in medical field and dental field, they have much reservation regarding this PMC, and I think that this should be solved in a better way. So we have the nice and smooth, what you say, dental and medical education in Pakistan. It should be promising one, and it should be what you say. It should be of a world standard.
Sure, sir.
But yet, because it is yet in process, so we cannot say anything final at this stage, and we have to see what actually used to happen in near future.
Sure, sir.
So approximately we have 1 minute left. Can I share my screen now?
Yes, sir.
Is it fine? It is visible?
Yes, sir, it's fine.
So you can start now.
Sure, sir. Assalamu alaikum. I am Dr. Ali Adam. Welcome you all in today's precious webinar on topic surgical management of trigeminal neuralgia. In this session, you'll be able to understand about two major things. Number one, injectable therapy, and second, neurectomy. This is our second last session of trigeminal neuralgia with our most worthy keynote speaker, Professor Dr. Arshad Mahmood Malik. He is principal of HBS Dental College, Islamabad, reagent International College of Dentists, Region 24, and honorary board member in Association of International Dentistry. There will also be certificates as well after last session of this course and quiz of this course. Our last session will be by next Friday, inshallah. And without wasting further time, we will move towards our today's webinar. Sir, you may start.
Thank you, lady. Thank you very much for introduction. Actually, we've been demonstrating the treatment of trigeminal neuralgia since last two lectures, in which we have covered the treatment with reference to the drug oral drug therapy, in which we discussed many medicine which are in use, and we have seen all the pharmacological effects of these drugs, and then we have seen that what are the latest drug therapy and what is the guideline for these therapies. And then we have discussed with reference to oral drug therapy, what are the combination therapies going on there. And we have seen so many new drugs which are launched worldwide, and what is their effects and what are their side effects. Today's our topic will be on two basic subjects. One is the injectable therapy, which will be under the umbrella of the injectable medical therapy, and second will be the surgical procedure. In the start, we will just cover today the extracranial procedures. I think that that you can understand that is an extracranial procedure involve the neurectomies. Extracranial procedure involve the use of the cryotherapy as well as the soft laser. So we will cover with these extracranial procedure today. While we are talking of the injectable therapy, it is a very uh, promising one that this is a basic treatment which a general practitioner will use injectable therapy. Injectable therapy, and what injectable therapy can I use in my private clinic. Actually, this injectable therapy, one should be very careful that if he has complete competency and have the complete hold on the injectable therapy, then he could perform this injectable therapy in a safe way. But if it are a person who has not the experience or has not got any practice under the umbrella of a senior person, I think that this injectable therapy may result into severe consequences. The injectable therapy is generally we use the dental surgeon or maxillofacial surgeon. We limit ourselves to the peripheral injectable therapy. The injectable therapy also being used to the Gacinian ganglion, and it is towards the moving to the Gacinian ganglion base by means of foramen ovale. Under the visual guidance, we enter into the Gacinian ganglion and inject there as well. This is a very drastic therapy and a very drastic procedure, and it has the many big complications because you are at the base of the brain. If your anatomical position is slightly changed, or what you say that if you have any problem with reference to your visual acuity, you are going to have very much problem there. So I will prefer that a peripheral injectable therapy under the safe hands is a good thing with reference to expert dental surgeon and maxillofacial surgeon. It has been known that injection of the destructive substances in the peripheral branches of the trigeminal nerve produces anesthesia in the trigger zone or in the distribution of spontaneous pain. So, by injecting these destructive substances, you can have the relief of the neuralgia for the time being or for a period where these injectable therapy have their effect. Ladies and gentlemen, we have these four generally used materials for the injectable therapy. It is very well known, bupivacaine, phenol, alcohol, and glycerol. In the very initial stages, the people used to start with the bupivacaine in approximately very initial stages of the approximately 20th century. We have the use of bupivacaine. It is a very long-acting anesthetic, and it is used sometimes with steroid, and it has been used without steroid as well. I will tell you that why the steroids has been used. These injectable therapies of the bupivacaine are given in the most proximal possible nerve site. Say I can say the infraorbital foramina, the mental foramina, or sometimes at the neural site. But people used to avoid bupivacaine at the area highly vascularity. The reason is that the bupivacaine basically is a very potent analgesic. It is generally available into 0.5% anhydrous hydrochloride bupivacaine, and it is given zero point 0.5 to 2 milligram per body kg weight, but it is without adrenaline. So maximum dose we can give to a person is 4 ml. That's the maximum dose. Ladies and gentlemen, the bupivacaine is given with steroid because it has a very drastic side effect. It can cause acute toxicity to the central nervous system, cardiovascular system, and has been reported the certain cardiovascular collapse and death. So the people has started using bupivacaine with the corticosteroid. But with the passage of time, bupivacaine has been eradicated throughout the world, and now the bupivacaine is never used and not recommended by any dental surgeon or the maxillofacial surgeon in these days. This has been used. It is just for your knowledge, and I have interpreted here that bupivacaine has been it is for many years, but nowadays it is being omitted. The second drug which is used in a very longer period in the start of the 20th century until the end of the 20th century, it has been used till the emerging of the new what you see product. Phenol has the C6H6OH formula, and this is it results into precipitation of the protein. Which protein? Which is on the periphery of the nerve. That is specially Schwann cells, especially myelin sheath. And due to this, it results into paralysis of the nerve ending, and thus it inhibits the stimulation of the trigeminal neuralgia. Ladies and gentlemen, this precipitation of the protein resulted into severe consequences later on, resulted into severe fibrosis, and sometimes people have seen that due to injection of the phenol, that there was the formation of the neuroma as well, and that resulted in the rather severe condition, worse condition of the neuralgia than before. This is injected because if you are going to inject the bupivacaine, phenol straightforward in the nerve, it is very painful. So first you give 1 ml of 2% lignocaine and wait for 5 minutes to get it anesthetized. After that, you are going to give 2 ml of 5% phenol in glycerin, and that is injected in mental, infraorbital foramina, or taking care not to inject these, especially phenol drastic injection into what you say blood vessel. That is a very very potent killer when you give into phenol into IV line. So this is a very drastic agent, and it is now very less used in dentistry due to its the side effects. It burns a lot, it give a lytic activity a lot, and sometimes it give erosion to the bony area as well. So by this mean, the phenol is not more preferred in these days. In the start of the 1950s, the introduction of alcohol been there. This alcohol injection really given a very promising breakdown in the treatment of trigeminal neuralgia. Alcohol being used uh, due to the reason that it gives a severe dehydration, and due to dehydration, you well know that there's sodium channel, sodium potassium channel is there, and this transmission is going on. When you dehydrate the area, the transmission of the pump and the sodium channels are being blocked. This dehydration results into severe vasoconstriction as well, which may result into lytic activity, and this lytic activity of the nerve results into local fibrosis, and that been very promising one. But it has been seen that the use of the alcohol straightforward is very painful, and the people has used that first in the start of the alcohol you are going to give 2% lignocaine, and that 2% lignocaine you give it just approximately 5 minutes before that. It has been what you say sign of controversy that some people used to inject alcohol without lignocaine, and what they say that the lignocaine 2% is dissolved in the water, and if you inject the lignocaine right there, and there is a more concentration of water, and then you are going to inject the alcohol after 5 minutes, you are going to you will not have the good effect of the alcohol, because there is the water, and alcohol is going to take the water right from there, which was you have given by 2% lignocaine. So that results into less effect of the alcohol. This remains a big controversial aspect, that whether we are going to give this injectable therapy of the alcohol with local anesthetic agent or without local anesthetic agent. But I favor that if you give a very less amount of 2% lignocaine, approximately 5 minutes before giving alcohol, you are going to give 2 ml of alcohol. This is more than that of the lignocaine. Then you wait for the 5 minutes, maximum lignocaine effect is there, and it is going to anesthetize the area as well, because the alcohol, when it is given to the naked nerve, it is really very painful. So the patient may collapse due to this pain which you have given without local anesthesia. You can inject this alcohol into a mental area, in the infraorbital foramina, or at the level of the lingula, but very much taking care that it should not be injected into the blood vessel, and that is you are going to use the aspirating syringe, and then you are going to inject the alcohol. The latest therapy, which is being very popularized in the start of the approximately after 1990, the glycerol injection has been very popular, and so many very good researchers in Pakistan, rather I will say the head of PIMS, Professor Rana Zahoor, and I will say Professor Aqib, he's the head of Lahore LMDC, and these people has a very good research publication in Pakistan, and they have contributed a lot of work in the glycerol injection, and there are so many other researchers as well in Pakistan with reference to glycerol injection. The beauty of the glycerol is that it is less drastic as compared to that of alcohol, and it has the same effect that of the alcohol, and it is very, what you say, very friendly to the tissue as compared to that of the alcohol. That's why the maximum glycerol has taken the position of the alcohol, and now it is preferred throughout the world. Rather than giving the alcohol, it is preferred that you give the glycerol. But remember one thing, the glycerol is a part of the body, and it is generally used in dehydrated form. The glycerol is never effective, never ever effective if it is not dehydrated. Some people used to bring the glycerol from the market, and they used to inject, and then they reported, sir, I have given the glycerol injection to my patient, but I have got no effect at all. Gentlemen, ladies, listen. Glycerol injection is only and only effective when it is in a dehydrated form, and dehydrated form is only available in a pharmaceutical companies, and it is sometimes prepared on demand. So good pharmaceutical companies and pharmaceuticals distributors, they used to prepare in their pharmacy. You give them order, and they prepare dehydrated form of glycerol, and they give it to you. So this is generally not available in patent form in the market. So you have to get it prepared by the good pharmaceutical companies in a dehydrated form. Not in Pakistan, it is all over the world. You have to get the dehydrated form and then inject it. It has a very good parameters which we used to use. That is 0.5 ml for infraorbital, 1 ml for mental, and 1.5 ml for the mandibular nerve, respectively. Now, I have just described, yeah, these uses of these chemicals, but the main thing is, sorry, main thing is their anatomical position of the injecting these things in a proper anatomical position. So if you have to get a good practice of local anesthesia to that very proper size, I used to prefer my students that before giving injection, you, for 1 day or 2 day, you call the patient and inject the local anesthesia right there where you want to inject. So you check your location of the anatomical position of the nerve, that it is properly anesthetized or not. Do not give these injectable therapies which has the sclerotic effect, which has the fibrotic effect, which has the dehydrating effect in a live living tissue. You are going to cause the fibrosis, you are going to cause the lytic activity in the bone, and you are not going to get the benefit of trigeminal neuralgia effect at all. So that is very important, that you must know the exact anatomical position before injecting. Now, if you are going to give the infraorbital injection, your anatomical position so accurate that going from the posterior to the canine, taking the infraorbital position, and measuring outside, that you have the exact position in the infraorbital area. And then uh, I used to say that better that you want to inject the glycerol, you just don't remove the needle. You keep the needle there and just remove the local anesthetic cartridge from there, and you insert the glycerol pocket there, and then you are going to inject it. Some people used to remove the needle and then they again insert the needle in same way. This is going to change your position sometime, and that is not very promising one. So it is very important that first you locate your needle, insert it there, inject the local anesthetic agent, wait for 5 minutes, and then remove that local cartridge from inside, insert the cartridge of the glycerol, and then you inject it. Remember, glycerol injection is not so easy to inject. It is very thick and you need a good force. And sometimes it is not very easy to inject by the local anesthetic needles. For that purpose, we used to say that use 23 gauge or uh, bigger needle for this local anesthetic agent, as well as to inject the glycerol. These small needle 25 or 27 is not promising needles for these uh, 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 injecting at this area. So after having a injection of the glycerol, you are going to have your finger right there in the infraorbital area and keep it there for few minutes. Some people used to say that after injecting in this local area, you are going to place the coarse swabbing there. That is sometimes good, because you are going to reduce the circulation and you are going to have the maximum local effect of the glycerol right there. If you keep this sponge for approximately 15 minutes, it is going to have the good vasoconstriction, and the glycerol injection will have the maximum effect. Now, for the mental nerve, you are going to inject it from the posterior side. Don't come from the anterior aspect. You could try to come from the posterior side. You are going to have the good access to the mental area, and same procedure you are going to have. First, you inject the local anesthetic agent, and then you are going to inject the glycerol. Ladies and gentlemen, then you are going to have the big inferior alveolar nerve block. This I used to say all to general practitioner as well, that before going to have the glycerol injection, remember very nicely that you are in a bharti gate, you are in a fish market. If you are going to have this injection in a bad location, then you are going to have the severe consequences. Remember, if you are going to back, you are going to inject into parotid gland, and you are sometime going to hurt the facial nerve, and that what is you have introduced, that is the paralysis of the facial area, or the eye, or drooping of the eye, or the flattening of the face, not for one day. You are going to have this more than 6 months sometime, and that the patient is never going to forgive you. So please, whenever you are going to inject glycerol in inferior alveolar nerve block, number one, you have the full control of the anatomical position, that you are not posterior to the lingula, and you are not too anterior to the lingula as well, because if you are too anterior to the lingula, you are going to hurt the lingual nerve, or you are going to hurt the buccal nerve as well. So that is very important to understand, that the inferior alveolar nerve block of that particular patient you must get. For that purpose, it is very good to understand that you have to exercise to your patient twice, thrice, every after one day. Call the patient again, and you inject the local anesthetic agent, and you see that your injection is right there, and you got the exact card on the next day as well. Then again inject, and then you see that your injection is right there, and you had accurate anatomical position. Better go for third day as well, and when you are sure that the anatomical position which you have achieved, that to that particular patient is very promising one, that I will say that you are allowed to go for the injecting glycerol in inferior alveolar nerve block. That is very important, because I have seen so many patients being given injection of the glycerol, and they are giving, they have sometimes paralyzed the lingual nerve, and sometimes they have paralyzed the facial nerve. They are given posteriorly. That is very important for the injection in the inferior alveolar nerve block. For the buck nerve, it is also very important. Go to just at the cemento-enamel junction of the 7 and go straight forward, touching the posterior limit of the just the external oblique ridge and going slightly above to that. That is also good. That if you go practice for 1 or 2 times to this patient as well, you are going to have the accurate location of the long buccal nerve. That is also very important. Then is very drastic and very important. Generally, supraorbital nerve block or supratracheal nerve block are not given in a routine pattern, and it is a very less nerve. That is the when we are studying the etiology of the trigeminal neuralgia, we have seen the least nerve which is involved, that was infraorbital, and we have injected the infraorbital nerve block just at the feeling the notch, supraorbital notch, and just above to supraorbital notch we feel it there. But remember, for this purpose, by giving injection in the infraorbital area, you must have in your mind that how many nerves you are dealing. Here, the very important nerve which you are dealing is the infraorbital, supraorbital, and supratracheal nerve. No doubt, the forehead it is supplying. And very promising thing is that sometimes we are going to inject this supraorbital nerve block for the people which are suffering from Ramsay-Hunt syndrome. Ramsay-Hunt syndrome is the herpes zoster infection, and it used to involve whole of the forehead. Real a very bad burning syndrome. There are so many clusters, and the patient gets relief at once if you are going to get the supraorbital nerve block by glycerol. Ladies and gentlemen, the thing is that if you are going to cross the superciliary arch and you are coming down, you are straightforward putting this glass rod into orbital area, and due to gravity, this the glass rod is going to flow in the orbit. Remember very nicely, you have sclera and you have cornea. These are the outer layers of the globe. Sclera has further 3 layers, but the cornea has 5 layers. Cornea is a very simple, very thin, but having the 5 layers. But the sclera is thicker, having 3 layers, and they have less vascularity. They are mainly fibrous capsule covering whole of the globe. If you are going to touch the glycerol on this area, remember this thing that this glycerol is going to cause the fibrosis on the surface of the sclera. And what is going to happen? There is the orbital extraocular muscles are there. They are going to get the spasm of this whole area, and you are going to hurt the orbital nerves as well, which are coming on the medial side of the orbit. So don't take this supraorbital nerve block as a very simple. You are going to have the severe consequences if you are going to give the more injection. I will prefer 1 or 2 drops is sufficient. And after giving the local anesthesia, you wait along. For your waiting is no matter, because this area is very precious area, and for waiting this area is no matter. This is what the supraorbital nerve block you have to go. Ladies and gentlemen, after getting the concept of the different nerve blocks and the nerve agents, you must be very careful, because injectable nerve therapy has these complications. They cause necrosis of the adjacent tissue. No doubt, you are injecting at the nerve, but nerve is attached to the adjacent tissue as well. sometimes it causes the fibrosis. Sometimes if it is running beside the glands, it's going to cause the fibrosis and necrosis of the glands at night. And sometimes that's why the alcohol is not being more popularized, and it is being omit these days because of its effect on the causing the neuritis. And this neuritis results into severe consequences of the adjacent area as well. So that is the injectable therapy which we used to prefer for the treatment of trigeminal neuralgia. Ladies and gentlemen, we have covered the medical therapy, and that medical therapy generally is by the general medical and dental practitioner. Oral surgeons, when the medical therapy is over, then the oral surgeon comes. An oral surgeon are recommended for the peripheral procedure. If the peripheral procedure fails, then we refer the cases to the neurosurgeon. It is very non-promising attitude that certain people, they prefer to send the patient directly to the neurosurgeon. Ladies and gentlemen, there are so many reasons of etiology which we have studied in the initial lectures of the trigeminal neuralgia. These etiology are many of them are extracranial etiologies. You are going directly to the intracranial etiology by referring the patient to the neural surgeon. No doubt, the acute conditions are sometimes so bad that the patient prefer that it is better that I could go for the intracranial procedure to get the prompt relief at once. But I will say that go for the first the medical therapy, go maximum of the medical therapy, go on lingering the process, use the combination therapy which we have discussed in the initial stages, then come to the oral surgeon. This medical therapy is failed, go for the injectable therapy which we have discussed today, and then we are going to refer the case to the oral surgeon. The procedure of the neurectomy is, I will say, it is limited to the oral surgeon only, because the general practitioner is generally not familiar of the routine procedure of the neurectomy, and sometimes the anatomical position of the neurectomies are so difficult that the general practitioner may be in trouble. So for your knowledge, I am going to refer all these things before you, that you can understand what is the peripheral neurectomy and what are the procedures we are going on there. The peripheral neurectomy comes under the umbrella of extracranial procedures, and that is the first surgical procedure we are going to perform. The surgical treatment of trigeminal neuralgia basically is the first thing, that is the nerve avulsion, or what we say as a peripheral neurectomy. Oldest, it has started in 18th century, and the most effective peripheral nerve destruction method can be repeated if the regeneration of the nerve is there, and a relatively a very reliable technique. Acts by interrupting the flow of significant number of the afferent impulses to the central trigeminal apparatus of nuclei. You stop the afferent impulses right there, and there is no effect in the central nervous system. But we have the limitation. These limitations that we use to perform the infraorbital neurectomy, inferior alveolar neurectomy, mental neurectomy, and sometimes very rarely lingual neurectomy. The complication, no doubt, surgical complications are there, but what the patient is going to get, that is the full anesthesia of the nerve, or deep hypoesthesia, and that is really hurting to the patients. Patient come to you, tell them, my face is like a stone. Doc, what you have done to me, that I cannot feel anything. But you have to get the consent of the patient that you are going to have the full anesthesia of this region after I am going to get the anesthesia, and give no warranty and guarantee. Ladies and gentlemen, you are dental surgeon, you are a operator, you are not God. You are going to give a therapy, you are going to introduce a therapy which you feel mentally or by your sign and symptoms of the diagnosis of trigeminal nerve and other investigation, you come to know that this infraorbital nerve is being affected. And if I am going to get the a version of infraorbital nerve, I am going to have I'm going to have the effect of I am going to get the relief of trigeminal neuralgia. But sometimes you do fail. The failure I am going to discuss later on, that why there is failure of neurectomy. You have cut the nerve and yet the patient says that doc, I am under the influence of trigeminal neuralgia. And that is why I say, what are the indication of neurectomy? The first thing is that the trigeminal neuralgia itself, it is a big cause. You are going to have the neurectomy. That's the first indication. That is trigeminal neuralgia. What is second? Now, this type of malignancy, it is really very painful, and you know that the surgeon is going to operate maybe after 2 months, maybe after 1 week, maybe after 2 weeks. The patient had the severe agony of this area. And sometimes this painful invasive malignancy, if you do the neurectomy, you are going to get rid of this painful area. Then, which I have described you know, this is a picture of Ramsay-Hunt syndrome or the herpes zoster infection. This is also very painful. If you are going to have the neurectomy of this area, you may get the relief for 6 months, because herpes zoster is a long-standing pain, long-standing burning face, burning areas. So sometimes you are not able to get the analgesic all the time. That is very important. So for that purpose, you are going to have the neurectomy of that area. You go for the lingual neurectomy, you go for the mental neurectomy. Say for this case, you are going to get the relief of the pain. Now, the contraindication of the neurectomy is the number one is the medically unfit, and never do it before 18 years. You have to go for the development of the mandible, development of the thing. It has been noted that the neurectomies of a developing jaws, if you are going to give the nerve lytic effect to the developing jaws, there is lack of generation of the bone, and you cause the retardation of the growth of the jaw. Obviously, medically unfit, hypertension, uncontrolled diabetes, immunocompromised patient, and all those which are the medically unfit, you are not going to have the neurectomy. This patient, cannot have the neurectomy. You have the developing all these things. Orthodontic people maybe are in line with me today. They can understand that if you are going to have the neurectomy of this area, the anterior superior alveolar nerve coincide with the infraorbital nerve, and sometimes middle superior alveolar nerve also coincide with the infraorbital nerve. These two nerves give a big stimulus for the eruption of the teeth as well. So if you are going to have the neurectomy of these patients, you are going to have the retardation of development of the teeth as well as the eruption of the teeth. So for these patients, neurectomies are not indicated. So there are multiple procedures in the neurectomy. Say, if I want to do the neurectomy of the ID canal, there are certain procedures in the inferior alveolar neurectomy cannot be performed, and especially when there is the impacted teeth. And the most important, which I have discussed before, that is when there is the effectiveness of the medical treatment is there. Ladies and gentlemen, remember one thing. No doubt we are discussing all these treatment with reference to trigeminal neuralgia, but the first priority is always the medical treatment. You are not going to indulge any type of invasive treatment to the nerve because it is a big organ. It is a big sensory organ. It supplies sensation of the heat, cold, touch, and so many things. And if you are going to cut this nerve, you are going to give the consequences of morbidity there. So that is not a better treatment. So when the medical treatment is effective, please don't step to the other treatment. Secondly, when the cryosurgery is there, no, neurectomy and the cryosurgery has a vast difference. Our very respected Professor Riaz Barais has a very good research on cryotherapy. Especially, he has written his thesis on the cryotherapy in his MDS, and he has got the remarkable result. He says that the C fibers, they are being spared, and without damaging the peripheral sheet of the nerve, you are going to get the lytic effect of the neuron, and that is a very important thing. In Pakistan, his research is being appreciated. There are so many other people, they have done research on the cryotherapy, and it is yet people say that if the cryosurgery is effective, please don't go for the neurectomy. You first do the cryosurgery. Then is the laser therapy. There are big controversy regarding the laser therapy. Diode laser and sometimes helium neon laser, giving the trigger zone and trigger zone with reference to acupuncture points. It has been advocated that giving the few joules of the laser therapy, you are going to get the benefit. Ladies and gentlemen, our last session, which I am going to display next week, I am going to discuss in detail the laser therapy. That is under the umbrella of the intracranial and other procedure as well. In the laser therapy, people has got the effect. They say by the increase of the effect of the ATP, by giving stimulus to the mitochondria in the neuron cells, you are going to generate the ATP, and that ATP activates the mitochondria. In that way, the healing process of the peripheral last peripheral area, that is a myelin sheet, it is going to recover. So it is yet people say that it is sometimes they say that it is not more than placebo. So I don't say that it is not more than placebo. It is not good, but its effectiveness is vary from patient to patient. So in some patient we get very good result, and in some patient we have not so promising result. So after getting the contraindication, I take the neurectomy step by step. First, we take the infraorbital neurectomy. Infraorbital nerve, you well know, it is branch of the maxillary nerve, which emerge from the brain from the foramen rotunda. Then it pterygopods and fish, Then from here it comes to infraorbital fissure, and from infraorbital fissure it comes into infraorbital canal, and then from infraorbital canal it emerged from just below to the approximately 2 to 3 below to the infraorbital ridge right in the face, and it gives three branches to the lower eyelid, to the lateral nose, and to the cheek. Sometimes it do give extra supply in connection with the superior labial as well as to the alveolus as well. So this neurectomy, when you are going to perform infraorbital neurectomy, remember that you are going to have the paresthesia or anesthesia of the lateral nose, the upper lip to some extent, then to the cheek as well as to the superior level. So these all areas which are right there, you are going to anesthetize. So my request is that before performing infraorbital neurectomy or any neurectomy, be sure that your patient has been convinced that you are going to have the paresthesia of all this area. Sometimes there is also slight flattening of the area as well due to lytic activity of the nervous area. Now, infraorbital approach, that is the uh, conventionalism. It is a U-shaped Carvel-Lux incision is made in the upper buccal vestibule in the canine fossa region. Mucoperiosteal fry. I used to say that do not increase the superior level. Just when you the attached gingiva approximately 5 you elevate and see the 5 of attached gingiva. Superior to that, you give a U-shape incision or the what you say C-shape incision. And now don't move above, because if you are going to move above, you are not going to cut the mucoperiosteum. You are going to sacrifice fibers of the buccinator muscle. Sometimes you are going to hurt the facial vein as well, or the superior labial vein as well. So these vessels are beside you. So don't go into the soft tissue. Just remain yourself in the mucoperiosteal area. After the mucoperiosteal is reflected superiorly, you have to locate the infraorbital foramina. I used to say that place your finger right there and intraorally move the mucoperiosteal on the right and the left side of the orbital area and locate. Do not go from the middle area, because sometimes if you are going to the middle area, you are directly going to cut the infraorbital nerve and during the elevation of the mucoperiosteum. That is a technical point, that do not touch the mid area by the mucoperiosteum area. You go on the nasal side above, and then you go on the zygomatic side above, and on getting the reflection on the lateral side and the medial side, and then you approach above, then reflect the tissue, you will get the infraorbital nerve right there, and which is very big nerve when it is in the tissue. And then you rotate it and evolves with the hemostat. And then sometime who used to pack our very respectable and what we say Dada Ustad, the teacher of all the oral surgeons in Pakistan, Professor Muhammad Said. He used to rotate the nerve in such a way that the peripheral nerves also come with it, and he used to pack with a gutter stick that we used to do as well. Ladies and gentlemen, this is the when you go for the entire trunk separated from the skin surface and hold with the hemostoid exit point from the foramina. That is very wonderful. You see the whole thick nerves you will see. You have gone from the medial side like this, then you have gone from the lateral side this. You are not elevating maximum from this area. While you are elevating this area will automatically, mid area will automatically be elevated. Don't stress your periosteal elevator here, because if you are going to hurt this area, sometime you are going to get the cutting of this nerve. You see, this is the live of the same patient of the cutting. You will see the infraorbital foramina. You cauterize the area. You plug it with a. Sometime I used to give the hemostatic cauterizing needle of the electrocautery into the foramina, so that the maximum contraction of the nerve will be decided, and over that we used to pack the gutta percha stick. Why you pack it the gutta percha stick right there? Because you are going to stitch this area. Patient after 4 or 5 years report back with the regeneration of the nerve or the formation of the neuroma there, and you say that you have done inferior alveolar neurectomy. He said yes. You take the radiograph, there will be plug of the gutta percha stick there. You will understand that the infraorbital foramina has been plugged. So it is a very good indication, a very good spot that you are going to have the plugging of the infraorbital foramina. It is slightly difficult, but not impossible. If a general practitioner perform this oral surgery, which I will never recommend, but he tried to attempt it, he must be very careful, because infraorbital nerve has a direct connection with the base of the skull, and it is going to have the emergence from the foramen rotundum and infraorbital fissure. This area also gets the supply to the supra-angular vein, which drain into cavernous sinus. And if you are not familiar with the anatomy of this area, you are going to hurt the area more. Sorry, ladies and gentlemen. You are going to hurt more. So, ladies and gentlemen, if you are uh, uh, in this area, so you have to protect your all vicinities, medially, laterally, superiorly, and inferiorly. And for maxillofacial surgeon, I will say that your finger from outside must remain in the infraorbital rim. You don't cross the infraorbital rim. That is also very important. And these are the important things anatomically, that you are not going to pierce this area. So that is the conventional way of treating the infraorbital neurectomy. Now we move to ventral nerve neurectomy. It is also a routine neurectomy which used to have in this area. We perform it. Just by having a mental vestibule C shape in CN, and then you used to elevate it. It's very obvious there. Its three branches should be severed, and after removing it from the foramina, it is better to block this area as well, and you are going to have the better twisting of the nerve, so that the maximum avulsion you can do. Now, after that, you can have the lingual nerve neurectomy. Lingual nerve neurectomy generally is not routinely done. It is a very, very less neurectomy being performed and it is not so difficult to perform as well. Just you go give the incision at the anterior border of the ramus slightly towards the lingual side, and lingual aspect is exposed. The lingual nerve is identified in the third molar region, just below to the periosteum. It is just beside, hardly 2 mm away from the lingual aspect of the last molar. And eversion or ligation of the lingual nerve is being done, but generally it is very less used and very less operated. Inferior alveolar neurectomy. As I have seen in my list of these audience, there are so many maxillofacial surgeons are there. It is my pleasure, and I'm thankful to all of these that they are before me. Inferior alveolar neurectomy is absolutely is the work of the oral surgeon. I will never recommend any general practitioner to perform inferior alveolar neurectomy. It is absolutely not domain of any general practitioner. It is really, you are working at the party gate. The inferior alveolar neurectomy is a very important location. On the medial side is the medial pterygoid muscle, nerve to mylohyoid. Just beside it passing is the lingual nerve. Superior to it is the infratemporal fossa, and you have the many things superior there. That is the pterygoid plexus as well, and if you are going more posteriorly, you are going to have the parotid deep lobe there. So this is the anatomical position, and anteriorly when you move, when there is pterygomasterics, you have the lingula area, and you have the sphenoid sphenomandibular ligament, and then you have anteriorly the buccinator muscle intermingling with the superior constrictor of the pharynx, and this making the pterygomandibular raphe, and here is the anterior limit. Considering this whole anatomy of the inferior alveolar nerve, you are going to perform the inferior alveolar neurectomy. I am going to take more time on the inferior alveolar neurectomy, especially because of the because inferior alveolar neurectomy is a very promising area where we have to perform the neurectomy, and generally there is more failure of the by the oral surgeon, that they are not capable of doing the inferior alveolar neurectomies. What are the surgical procedures which are being advocated for the inferior alveolar neurectomy? There is one extraoral procedure which is done by the P.P. Borlase procedure, and two intraoral procedures. One is called the Queen's procedure, and second is called the Dandy's procedure. I am going to describe practically as well. There will be demonstration, but I am giving you more detail of the inferior alveolar neurectomy, because the inferior alveolar neuralgia is more. Vector neurectomy failure results into performing of the inferior alveolar neurectomy. Sometimes a patient has many times the glycerol injection in inferior alveolar area, and you have to perform the inferior alveolar neurectomy later. The first procedure, which is Dandy's procedure, it was in the very initial stages. Dandy's, he was a neurosurgeon basically, and he has described many procedures in the neurology. He has done intraoral procedure for the inferior alveolar neurectomy as well. Second procedure was done by the Queens. and that was done in 1965. And he has done by the lateral approach. Dandy's approach was slightly difficult. The Queen's has performed an easy approach, but this approach has also certain limitations. Then TP Morley's approach. It was done in 1980, and it was the extraoral approach, and this has also there's good effects and side effects as well. We will take all these procedures step by step. Then you see that is the anatomy of the very important thing to understand is this phenomandibular ligament, which I have specially demonstrated this anatomical procedure. You see, you are going to approach from here, and you are going to have the approach of the nerve. Right above is the branch of the internal no, I will just repeat this again. I will say, please listen to this anatomy again. So by repeating this, you understand that the branch of the maxillary artery, then the vein, and the sphenomandibular ligament. You have to see these all anatomical location, and you have to remove these hurdles, and you have to approach right there in the liver. Now, what is the fun of giving this description? This description actually gives you a detail of the extra innervation of the inferior alveolar nerve. You see the inferior alveolar nerve, I cut it from the foramina here. But the accessory nerve is coming from the superior level, and it is innervating 7 and 8 area. You go for the neurectomy of inferior alveolar nerve, and after that patient reports to you, the doc, you have done a big surgery to me, and yet I have the same problem. It is not by the your any problem, it is by the extra innervation which is right here, and you have cut the nerve right here, and this the innervation you is yet going on with these two teeth. So these are the extra innervation of the inferior alveolar nerve, or the nerves by the mylohyoid nerve, or from the lingual or the buccal nerve. These give extra innervation to the teeth of the mandible. And whenever you go for the neurectomy of the inferior alveolar nerve, this should be remembered that you are going to have the extra neurological problem or neurological failure after neurectomy because of these extra nerve supply. I repeat again this video. Please listen. So that is the thing that every surgeon must understand. Just I will request all of you that there is a problem of the for just a second, there is a electric supply is less say in the computer. I just have to insert the electric supply. Just for 1 minute, please excuse me. Very sorry, everybody. Thank you for your wait, and it was a really problem for me that there was an electric. It was without electricity. Ladies and gentlemen, we were talking about the extra innervation of the inferior alveolar nerve and how it is being supplied. For the recontinuity, if you permit, I can replay this extra innervation of the inferior alveolar nerve for your knowledge again, please. Can you listen? My sound is there. So these are all the external supplies. Now we move to forward. This is just a simple description of all the anatomy which we have seen. You see, this is the sphenomandibular ligament. Beneath the sphenomandibular ligament is the inferior alveolar nerve coming. So for approach into the inferior alveolar nerve, we have to cut the sphenomandibular ligament. For the oral surgeon, I really request that whenever you open this area, first locate the sphenomandibular ligament. And when you cut the sphenomandibular ligament, you will see the inferior alveolar nerve just emerge in front of you. people going on tracing the nerve right here, they don't trace at the area of sphenomandibular ligament, which is right there. If you cut the sphenomandibular ligament, the nerve is removed. Never go more above, because the branches of the maxillary artery are right there, and you may hurt any of the branch. And more inferiorly, there is no use. The anatomical location of the inferior alveolar nerve is right there. You see, we can approach the inferior alveolar nerve right here. We can approach the inferior alveolar nerve right there, or intraorally from here. So that is the anatomy of the approaches. This is the ring which I have made outside, and internally, if you see on the medial side, that is the lingula. We are going to have the approach right here. And if we dentate, there is slight elevation of the from angle to here, and from the occlusal plane, you move backward, and just below to the occlusal plane, you will see the area where you are going to perform the neurectomy. This is another very important area, that if you are going to get this block out from the external oblique ridge, you are going to see the inferior alveolar nerve right there. This is the mental foramina, and this is the vicinity from where this inferior alveolar nerve is coming. So if you remove this block, you are going to see the inferior alveolar nerve. So ladies and gentlemen, after having the concept of the anatomy, we are going to start the inferior alveolar neurectomy by Dandy's procedure. Dental procedure is the oral incision along the internal oblique ridge. Approach the lingula by blunt dissection. Separate the nerve from the sphenomandibular ligament. This which I have indicated you very initial stages, that you have to localize the sphenomandibular ligament. Avulse of the nerve from the canal after mental neurectomy. This is very important, that you remove the nerve from the whole of the mandible, you cut the nerve from the mental area, and then you avulse it from posteriorly. And that is the Dandy's procedure. How? This is the lady. We are going to have the neurectomy of this lady of the inferior alveolar nerve by Dandy's procedure. This patient was suffering from the trigeminal neuralgia, and she reported to us. We have done the mental neurectomy right here, and we have cut the mental nerve right there, and you can have the stitches after doing the mental neurectomy. After doing the mental neurectomy, what we are going to do is the incision along the internal oblique ridge. This is the incision. This is pterygomandibular raphe, and you are going just outside here, and you are going to have the incision and touching the bony part of the external oblique ridge here, and coming from the internal oblique ridge, moving towards the external oblique ridge right here. Then you are going to have the exposure of the internal side of the mandible, and that you locate the sphenomandibular ligament, and that is right there. After location of the sphenomandibular, you cut the sphenomandibular ligament, and you see the nerve is right there. That is the inferior alveolar nerve placed right there. Then this is the lingula, and that is the nerve which you have traced, and that is with the forceps. And you see, this is, you have traced it out from the area, and now you are going to have the ligation of the nerve. Now you have removed it from the, because from anteriorly you have removed, you have cut from the mental foramina. Now you can avulse the whole of the nerve from here, and then you ligate it on the posterior. There's controversy that you ligate it or cauterize it. I used to ligate it. Some people used to cauterize it. It is no matter whether you cauterize it or you cut it. Then this is the ligation of the nerve. You have cut the portion of the nerve which you have evulsed from the inferior alveolar canal, and then you are going to have the stitches in this area. So that is what the dentic procedure is. The advantage of this dentic procedures is that there is no bone cutting. Intraoral approach, there is no facial scar, and less chances of regeneration of the nerve because you have evulsed whole of the nerve from the inferior alveolar canal. The disadvantages of these procedures is the damage to pterygomandibular raft, number one, because you have to cut the pterygomandibular raft sometime and you have to approach the medial side. Difficult approach due to improper vision. It's too dark, it is too posteriorly, and sometimes your light cannot approach there. So your vision is very improper. More facial spaces are open to infection. What the space is? Medial pterygoid space right directly there. Right superiorly, you can see the deep temporal space is right there, and posteriorly is the most drastic. The lateral pharyngeal space is right there. So the more infection chances and deeper infections are there. Cannot be performed in restricted mouth areas, especially the patient with the microsomia, patient with the macroglossia, or with what you say having trismus or micrognathia even. It is very difficult to perform with the micrognathia as well. There are chances to the damage of the lingual nerve and the mylohyoid nerve. Obviously, these both nerves are in your way, and especially if you are going to damage the lingual nerve, it is a bad consequence. So the second procedure which is being done is by the Queen. He has performed this by giving the incision on the lateral border external oblique ridge to 0.5 to 1 mm below to the attached gingiva right here. He has made the rectangular bone window right here 0.5 to 1 mm at the lower level of the anterior border of the ramus right here. He has exposed and reversed the nerve after mental neurectomy, and then pack the bone chips or the bone wax in the bony defect and then stitches. This is it is like this. You are going to have the lateral aspect of the bone cut like this. You can go by the lateral approach, make a window, you make the rectangular area, and from the medial side and the lateral side and posterior and anteriorly, you cut it and remove this whole portion. Sorry, the photograph is like this, and you remove the whole of this area, and you see it is like, and that is the inferior alveolar nerve, you can see, and that is by the Queen's approach. You see the photography, a still photography, that is more easy. You go for the cut, you elevated the area, this is the flap, then you make the window, remove the window, then you are going to have the nerve right there. This is the mental area. You have gone for the neurectomy of the mental nerve as well. You remove and avulse the nerve right here, and that is the neurectomy done. Then you place the antibone sponge right there and going to have the stitches. Ladies and gentlemen, this is a very simple procedure because it is not so deep. It is visibility is there. You are working in the oral cavity rather in the pharyngeal area, and your visibility is there. less facial spaces involved because you are more anterior. There is only, if you go slightly posterior, so you can involve the uh, mesenteric space, and slightly to some extent the buccinator, what is the buccal space as well. Some mandibular space generally not involved because you are on the lateral side. Intraoral approach, no facial scar, no damage to the lingual and mylohyoid nerve because you are in the oral cavity, not posterior aspect. Better vision for the surgical exposed area. You can see you are looking at that. Now, what are the disadvantages? The disadvantages are that you are in the bone. The few portion or a posterior aspect of the nerve, it is you have not cut. And the posterior stem remains within the bone. So that is the chances of regeneration of the nerve is there. And especially if the 8 is present, a deeply impacted 8, then you cannot open this area. That is also. The bone cavity, if it do not heal, it may result into idiopathic bone cavity or the traumatic bone cyst or like that. That may be a complication with reference to Queen's approach. Now we are moving towards the last procedure of the inferior alveolar neurectomy. It is done by the TP Morley's. It is an extraoral procedure. He has given the submandibular incision 1 into 1.5 inch in the antegonal region, approximately midway between the last molar and the angle of the jaw. Midway. He has reflected the masseter muscle fiber separated from the periosteum, and he reached to the bone. 0.5 mm circular bone window is made. And he exposed the nerve and infers after the mental neurectomy. Intraorally, he has done the mental neurectomy, and extraorally, he has done the ID neurectomy. Pack the bone wax or the bone chips right there. So, what he has done, this is the extraoral area where the mental foramina enters, give its entry to the inferior alveolar canal. You cut the nerve right here, and then you avulse whole of the nerve from here. How? This is the patient. Sorry. This is the midway between the last molar and the angle of the jaw, and you have elevated the muscle more up that it should not be within the vicinity of the marginal mandibular nerve of the fascia. You cut it and you elevate it superiorly, and here you elevate the masseter muscle. You see, the masseter muscle is absolutely separated. It is not being kept. It is separated by the dissecting scissor, and you approach to the mandible. While approaching to the mandible in this area, you make a window. You make the window like this, and after making the window, you approach deep, and you avulse the inferior alveolar ID nerve right here. You see, just here, posteriorly, if I say, this is the part of the lingula. From here, the nerve is entering inside, and here it is going into the mandibular canal and inferior alveolar canal. So that is the area where we have reached for the mandibular neurectomy. So we have avulsed the nerve right here. You see, we have removed it. This is the canal area going into the mandible, and we have removed this whole nerve from the mandibular canal and avulsed it outside. And here, the area we have ligated it by the resorbable threads, or you can cauterize it, and we push it on the medial side or the lingua. That is the area where we have done neurectomy. That is the empty space of the nerve canal. Then we pack the sponge, bone, or whatever you like. You can pack it there, and in layers you stitch, and that is the TP ball is technique on inferior alveolar neurectomy. The advantages of this nerve neurectomy is that there's no damage to the lingual nerve. You are outside. There's less chances of regeneration of the nerve because you remove whole of the nerve from the canal. Less facial spaces are involved, only the mesenteric space is involved. Better vision of the surgical exposed area because you are outside, and less chances of post-operative infection because you can maintain the integrity of less infection in this area. What are the drawbacks? Number one, and that is a very bad, that is the external scar. No doubt these days the sutures, very good sutures are available, and you can have these sutures good. Bone cutting procedure that may result into the idiopathic bone cavity, damage to greater auricular nerve or cervical branches of the facial nerve if you are not careful enough. So, ladies and gentlemen, that is what we have today. It is very great to stand beside the great mountain, and it is also great to stand beside the great people as well. I am very lucky that today I am before you. You have very lovely company with you, and you have listened this whole lecture. And thank you very much, all of you. And it is over to organizers. I think that there may be many questions, and you can ask this question. First, I will give the opportunity to all those who have written the question, and then I will give a chance to the senior who are here to give their comments, and if they have any query, they can ask you. Ladies and gentlemen, thank you very much, and it is over to the organizers. Thank you very much. Yes, Dr. Hiran is there.
Yes, sir, I am here. If anyone has any question, you
Assalamualaikum, sir.
can ask.
Ji, sir. Thank you, sir. It was a very great lecture, and we all enjoyed every bit of it and learned something
Dr.
new.
Rehan?
Sir, Farooq here. I will end the session. Basically, the lecture was very good, sir. First of all, if anyone has question, he or she can write their questions in the comment section as well, in the chat box, and then sir will move one on one to their question.
Yes, I am here to answer.
Yes. So this is a basically question answer session. So you can ask yourself as well if anyone wants to like ask sir by opening the mic, he or she can let us also know. You can also ask by opening mic as well.
Actually, I start from Dr. Khalid Rashid. Are you listening to me? Hello?
Dr. Khalid Rashid. Dr. Ryan, kindly unmute him so that he can uh, answer, sir.
The The first
Meanwhile,
question, what is the difference between trigeminal ganglion, Gaussian ganglion? Why did you call it the name? It is actually the difference of the appearance of the ganglion. Gasseri is a regional location. That's why it is called. Rehan, I cannot listen your voice. Hello,
Hear me now?
मैं आपकी आवाज सुन रहा हूँ. Are you listening to me?
Yes, exactly. I am listening.
But why you are not answering during my conversation?
I am answering, but I think there was mic unmute issue.
I am unmuted, but I cannot listen you.
and Dr. Rehan, kindly unmute Dr. Khalid if he is
Hello?
present.
Hello?
Yes, yes, sir.
Yes, sir.
Can you listen me? Okay, we are going to have the first question from Rashid. He says that what are the difference between trigeminal ganglion and Gaussian ganglion? It is an anatomical distribution due to location, and Gasseri is actually is a locational terminology used for the Gaussian ganglion. Second is, sir, please convey this slide to us, study along. Can you read the question for me?
Okay. Sir, there is no question. People have asked if they can get this lecture slide or where they can watch. So you guys can watch this recording basically on the YouTube channel of Association of International Industry Aid, and it's up to sir if he shares his slide as well.
Uh, I think there are so many seniors I have seen in my uh, here.
Sir, there is a question for you.
Yes.
Numan has asked that what is the latest method we are using now for inferior alveolar neurectomy?
Actually, the best thing is that yet people favors the Dandy's approach. They don't favor extraoral approach. They don't DP Marley's approach or uh, um, other approaches. They yet favor the intraoral approach, and they say that is the most promising one.
If anyone has question, she can ask sir, and they can also unmute themselves if they want to like ask by on mic basically. Dr. Khalid Rashid, if you want to ask question or you can want to like talk to sir, I have unmuted you. You can unmute yourself and you can ask sir as well.
Yeah.
Sir,